Hi, everyone. How are you? Good evening or good day, wherever you are. Welcome to tonight's webinar, Insights and Hope When Living with a Device. We're very excited you could join us this evening. I'm Rachac, Director of Education and Information for the DCM Foundation. And all participant microphones are on mute upon joining. If you do have any questions, please use the Q&A feature. And we have a lot to cover, so we will get rolling. For those who don't know, the DCM Foundation's mission is to provide hope and support to DCM patients and their families through research, advocacy, and education. And a big piece of what we do are these monthly webinars. So stay tuned for those throughout the year. Tonight's webinar format is an interview format between the presenters, and we will have an open Q&A session following the presentation, so please feel free to drop your questions into the Q&A feature at any point. Next. First, we are going to do a quick poll. Which best describes you? I have a pacemaker, ICD, CRTD, or other heart device. I don't have a heart device, but I may be getting one. I am a family member or friend of a heart device patient, or none of the above. We'll give a few seconds here. We had a lot of interest in tonight's webinar, so it's a real popular topic. Okay, let's share the results. This is great. So almost 70% of people on tonight have a heart device of some type, so that's great. 11% don't have a device, but maybe getting one. And so there's a lot of information for you as well. And family member or friend, 16%. So there's going to be great information for all of you. So let's continue on tonight. We are going to be covering a variety of topics tonight related to devices, including types of devices, criteria to get a device and why get a device, fears and anxiety, and not just before you get a device, but also for those who already have one, how to deal with that, recovery after the implant procedure, and living with a device. Next slide. First, I'd like to introduce to you Doug Rachac. Doug has been on with us a couple of times before. He is former employee of a major heart device company and a current med device patient and advocate for other heart patients. He spent 14 years working for Medtronic, and in 2014, due to several episodes of syncope and tachycardia, he received an implanted Medtronic defibrillator. He then left Medtronic in 2015 to recover, volunteer, and be a stay-at-home dad. He now advocates for device patients and consults with the medical device industry. And Doug, I hear you've been working on some interesting things lately. So if you want to give us a quick update on that, that would be great.
Yeah, thank you. Nice to see you again, Jayanne. Yeah, for about the last year and a half, I've been consulting with one of the large major medical device companies, working on what they call the patient-focused initiatives. So these are projects that are going to impact patients in the future, patients like me, patients like the people who are joining us today. It's been really fun, a good time. I've really enjoyed it. Tonight, I'm not here to speak on behalf of any medical device company. I'm using my experience for the last 25 years and especially the last 8 as a device patient to share my knowledge and hopefully help some people understand the products that they have a little bit better.
Fantastic. We're looking forward to all the information tonight. So we're going to get back to Doug in a second. Next slide, please. I am very excited. We also have 2 special guests tonight from the Ross Heart Hospital at the Ohio State University's Wexner Medical Center. And we have Dr. Savona and Julie Mease, and I'll be introducing them in a moment. As you can see from some of these statistics here, this is a quite impressive heart hospital, nationally recognized for excellence in heart and vascular care. And I have to say, I personally am super thankful for the work they do because our own executive director, Greg Roof, some of you may have seen on prior webinars, he received a successful heart transplant at Ross Heart Hospital on July 15th of 2021. And that is also where he received excellent care and treatment for his DCM and heart failure prior to his heart transplant. And as you can see, some of these numbers are just quite impressive. 55,000 annual admissions and outpatient visits. I won't go through all of them, but over 7,500 annual cardiology procedures and over 2,700 annual cardiac and vascular surgeries, advanced heart failure care, offering all available therapies and trials of new devices, and over 4,400 electrophysiology procedures annually, which places them among the highest volume of these programs nationally. So next slide. Again, I'm very excited to introduce to you Dr. Savona, electrophysiologist from Ross Heart Hospital. Dr. Savona earned his medical degree from the University of Florida. He completed his residency and fellowship at The Ohio State University, where he then also served as a chief resident and chief fellow in electrophysiology. He's a member of several professional societies, and his clinical and research interests include clinical electrophysiology, inherited arrhythmias and sudden death, device management, and ablation. And also joining us from Ross tonight is Julie Mease, APRN CNP, who has over 20 years experience in the field of electrophysiology and cardiac devices. She holds a master's degree in nursing, and she is the lead nurse practitioner with electrophysiology and the cardiac device clinic. She has been in that role for the past 10 years, and she also is certified as a clinical cardiac device specialist. So Dr. Savona and Julie, welcome tonight. We thank you for being here with us. They are going to be on to answer your questions as well during the Q&A portion. So let's get rolling. Next, I want to talk with Doug and ask him some questions. If we can move over to Doug, great, excellent. And so Doug, this is really exciting stuff. I'm so glad to have you on again tonight. I know there are several types of implantable devices that you'll be talking about, including pacemakers, ICDs, CRTDs, et cetera. Can you help us understand the differences between them and what they're used for folks who may not know?
Sure. There's a number of different devices that can be used to either diagnose or treat different heart conditions. The ones that I'm going to be covering today are more of the implantable devices. It would start with a little device like this. This is called a loop recorder or a cardiac monitor. This is actually inserted under the skin, and all it does is record your heart rhythm and save that for your doctor to look at later. The goal is to catch what rhythm you're experiencing so that a proper diagnosis, or at least a direction towards a diagnosis, can be made. Once a diagnosis is made, one of the products that you might get is a pacemaker. This is a very small device. It's used for keeping hearts from beating too slow or from pausing. Sometimes hearts will pause 10, 20, 30 seconds, and we want to prevent that. This is inserted right under the skin in the kind of the meaty part of your chest. A lead wire is then fed down into the heart. This is a lead wire, very flexible. It snakes down into your heart until it touches the heart wall. And then small electrical impulses are sent down there to keep your heart beating normally. Now that is a traditional pacemaker, but the newer models that are out there are this small. This is called a leadless pacemaker, and it's leadless because it doesn't have any leads. This is actually placed directly inside the heart, which is amazing, I think, absolutely amazing technology. You can see the size difference. Both of these are used. You might get a traditional pacemaker, you might get a leadless pacemaker. After that, we have defibrillators. This is what I have. This is a little bit bigger. So you can see here's your traditional pacemaker, and here's the size of a defibrillator. This is used to keep your heart from going too fast. And this is when you're experiencing a rapid heart rate, over 200, 240, 250 beats a minute. This little guy will step in. It can deliver pacing impulses to try and stop that fatal rhythm, or if it can't stop it with the pacing impulses, it will deliver a shock that will revert the heart back to normal rhythm. And then the other devices are called CRT, or cardiac resynchronization therapy. These are either pacemakers or defibrillators, but these have 3 lead wires. And the important part is that the leads on the ventricles are on either side of the ventricle. So they go to the bottom side of the heart, and they get the heart to beat together, the bottom chambers to beat together. And that resynchronizes the heart which will make people feel better usually, and it can help reverse some of the effects of heart failure.
That's amazing. I mean, the lead list is so small. I'm so impressed. Obviously technology has come a long way
Sure
and
has.
continues to. That's excellent. Thank you so much. And so that's kind of a basic overview. I wanted to talk next about the criteria to get a device. And Dr. Savona, I'd love to have you on for this portion for a minute. Thank you again for joining us tonight. It's a pleasure to have you here. Can you talk a bit about the criteria for getting a device? Who is eligible and how do they determine that?
Yeah, sure. Yeah, thanks, Doug, for the introduction, because that's going to make my job easy. So, each device that he showed has a different indication. So, kind of starting where he began with pacemakers, every device he showed can actually pace the heart. So, if the heart goes too slow, the defibrillator, the pacemaker, the CRT, all those devices can pace the heart.
Mhm.
In some patients, they just have a slow heart rate and they only need a pacemaker. And that's when we would consider that device. And the criteria typically for that is if you have symptoms related to a slow heart rate, or if you have something like the conduction in your heart doesn't work correctly, something like complete heart block.
Mhm.
In general, those are going to be the main indications for a pacemaker. Certainly, there are kind of nuances to that and certain disease process, but in general, it's symptoms related to slow heart rates, or if you have heart block, that's like complete heart block where there's no conduction.
Mhm.
Now, a defibrillator, as Doug mentioned, is very helpful for if you have a fast heart rhythm, something like a ventricular arrhythmia or rhythm from the bottom chamber of the heart. And the role of that device is to shock the heart back to rhythm or even pace the heart rapidly to break the arrhythmia. There's two main criteria that we think of when considering a patient for this. First would be if they've had an event previously. So if they've had a documented arrhythmia, or if they've died suddenly and been resuscitated, that would be what we call a secondary prevention device. And we would put in a device to prevent further events. The other would be if we can determine if a patient is at higher risk for having these, but has not had one of these problems. And that's usually based on if the pumping function of the heart is low, typically less than 35%. And usually, if we find that a patient has a low pumping function, we would put them on the best medicines possible, make sure there's nothing that we can reverse. And usually after about a 3-month period of being on the best medicines without any reversible causes, then we would consider putting the device in. And the reason we don't jump in and just put it in right away is because sometimes the pumping function improves and the risk of having a bad rhythm gets much smaller and they actually don't benefit from the device.
Mhm.
Now, the final device Doug talked about was called a CRTD or CRTP, which is a cardiac resynchronization device with either a pacing function or a pacing and defibrillating function. Those are very sophisticated devices, and typically we use those for people who have certain issues with how the heart conducts electricity. It's something called a bundle branch block, and typically if their conduction is sick, then they would benefit from one of these devices. And that's something where we look at the EKG to help make that decision.
Okay, fascinating. That's great to know. And even though we've had these webinars twice before, I didn't know any of that. So thank you. I really appreciate
Oh,
that.
no problem.
And I know that there'll be questions related to all this when we get to the Q&A. So thank you again.
Yeah.
So let's go back to Doug now for a second and talk about why get a device. So we understand now the criteria that determines when a patient needs to get a device. And I'd like to explore more about why someone should consider getting a device. Can you talk a little bit about that?
Sure. Yeah, a number of reasons. Really, for pacing indicated patients, people who are possibly going to be getting a pacemaker, they will likely be experiencing symptoms, things like lightheadedness, dizziness, tunnel vision, shortness of breath when they try to go up a flight of stairs, for example. A pacemaker can help bring that heart rhythm back to normal and help a person feel better, physically better. So that's the main reason why you would get a pacemaker, is to feel better and to prevent that heart rate from dropping too low. For defibrillators, the main purpose of a defibrillator is to prevent sudden cardiac death. And sudden cardiac arrests are a big problem in the US. Around 350,000 people die every year from a sudden cardiac arrest. The survival rate is horrible. Out of hospital, the survival rate is about 7%. And that's even with CPR and AEDs out there, it's not great survival. With a defibrillator, though, that rate jumps incredibly. And I've seen clinical studies that show a survival rate of around 97%.
Wow.
And Greg, actually, from the DCM Foundation, experienced that himself when he was waiting for a heart transplant. His heart was very, very weak, and he was shocked multiple times and saved by his device. So even in that sick state, the device was able to put the heart back into rhythm. For the CRT, it is the same as kind of the pacemaker. The main reason is because the patient is feeling horrible. Their heart function has decreased to a point where they're feeling sluggish, they're feeling tired, fatigued, again, winded when they walk. So the CRT device will help recover and help the heart recover and help the person feel better as they're moving about.
That's great to know, because I hadn't thought about it in that regard. You know, you usually think of it as, you know, it helps save someone's life, that sort of thing. But certainly with regard to feeling better, and if you're feeling better and more active and staying more healthy across the board, that's always a good thing, right?
Right, and these devices do save lives. I mean, pacemakers will prevent long pauses, which people can die from. Defibrillators will, of course, save you from sudden cardiac death, and then the CRT will save your life if needed. Definitely.
Yeah, it's amazing technology. So let's talk just a little bit about fears and anxieties. I know whether a person has a device currently or they're thinking about getting a device, I'm sure that, you know, fears and anxiety creep in. It's just kind of a natural state of being human. Can you talk a little about this and how you've dealt with that yourself?
Yeah, this is probably the biggest concern that I hear people talk about when they reach out to me. It's natural. It's the fear of the unknown. Most people understand what a pacemaker is, or maybe know what a defibrillator is, but they don't know the specifics of it or what it means in terms of their life when they are presented with the option of getting one. So there's a bit of a learning curve. I have found that learning about your device, learning about your condition can help you alleviate some of the anxiety and fear. It's just the fear of the unknown. Once you understand how a device is placed inside the body, once you understand how it works and what it's supposed to do, it makes it a lot less scary. But anxiety is huge among the people who have a condition that would require one of these devices. In the normal patient population, or the normal population, about 7 to 9% of people experience regular what would be clinically diagnosed as anxiety. In the population of people that we work with, it's around 35%. So it's a normal thing. This happens all the time. And I should note that it's not just the person who is experiencing the heart issues that can experience anxiety and fear. It's also the family members who are with them, the caregivers that take care of them. So it's something to watch out for, to be aware of. It is definitely something that may creep into your life, but there are definitely ways of dealing with it. In some cases, in my own personal case, sought professional help, but with a psychologist and a therapist. So it's very helpful for me to kind of wrap my head around this new normal of having this medical device in my body.
And I was just talking recently, and everyone I've met and spoken to, I speak to a lot of DCM patients, as does Greg Roof, being our executive director. And the people who seem to be handling it the best, if there is such a thing, all have sought professional help. All have sought out a therapist, psychological assistance through the process. And I just want to applaud that, because I think that that's really important for folks to consider, and make their lives easier, and also for their families, like you're saying. Excellent.
I can't recommend it enough. Lifesaver.
Yeah, absolutely. So let's talk then about recovery after the implantation procedure of getting a device and getting back to life. And, I know there's recovery times vary, but what's a typical recovery look like from that procedure, and how soon can you get back to living life normally?
It does differ by procedure and by device. So, a micro device like this, the recovery time is only about 2 or 3 weeks because the entry point is in the femoral artery in the groin area. So it's a very small entry point, and then there's not a lot of recovery time after that. With a typical device, a pacemaker, let's say, or a defibrillator, the recovery time is a little bit longer. They're making an incision in your chest. There is a little bit of trauma there, so you want to be careful not to reopen that incision. And the general recovery time, the recommendation is about 6 to 8 weeks of just taking it easy, listening to your body, not overdoing it. Many doctors will recommend that on your implant side, mine is on my right side, so don't lift your elbow above your shoulder for 6 weeks. You can continue to move your arm around, but don't lift it up high. And really the reason is they don't want you to open up that incision. And then there's also a belief that if you stretch too far, if you stretch for something on a top shelf, you can actually pull the leads out of the heart. And there's not a lot of evidence that shows that's true, but it does sound like it makes sense. So it's just a good idea to take it easy after the procedure, let your body heal, and then you can get back to normal. And by normal, most doctors say by 8 weeks, you should be able to get back to your normal routine, which means if you used to run marathons and you feel comfortable at that point, you can start training again for marathons at about 8 weeks.
That's absolutely incredible. And when we were preparing for this, I know you had also mentioned, some people kind of favor it so much that they don't want to move their arm much, and that's a problem too.
It is. You can actually develop what's called frozen shoulder. Now the muscle can atrophy and freeze in place. And this happened to me when I broke my arm and I didn't move my elbow enough afterwards. Physical therapy for that is not fun. I don't recommend it. So just keep moving your arm normally after the procedure. Don't lift heavy items. Don't stretch too far, but just move your arm around normally and it'll be all right.
Okay, excellent. And so this leads us right into what it's like living with a device. Can you tell us a little bit about your experience living with a device? Have you been able to get back to a full and active life? And are there any things that you can't do now that you could do before?
No, I really haven't had any concerns like that. There is, after the recovery time, you can get back to your normal life. So there are no real restrictions that I worry about in my daily life. I don't do anything crazy, but my doctor has told me that my device is there to protect me, not restrict me. And so there's nothing that I am restricted from. Now that's more of a result of my condition. My heart condition doesn't limit me, but specifically the device itself doesn't limit me. So, if I used to work in a wood shop, I can still do that. There are some precautions to take. For example, working with running engines, the engines generate an electromagnetic field, and you don't want to be too close to the electromagnetic field because your device can pick up on that electrical signal and it can get confused thinking that that's the heart rhythm. So it can pace your heart when it's not supposed to, or it can withhold pacing when it should be pacing. It could cause an inappropriate shock, which I've never experienced, but I hear are not fun. There's just some precautions. Most of the times, just 6 inches of distance between whatever you're using and your device is more than enough. A larger item like an engine, 12 inches is more than enough. And then there are some few precautions like welding. You can still weld. There are precautions to take with how you set up your equipment and how close you are so that you can get back to life. But in general, your device will not limit you. It may be your heart condition that limits you for example, if you can't run a marathon with your current heart condition, your device won't prevent you from doing that, but your heart condition might.
Right. No, that's a great point. So what are a couple of the activities, for an example, that you partake in, just to give people like a for instance?
Sure. I mountain bike. I am a road cyclist. I exercise. We got a Peloton one year for Christmas, and that was a mistake. I'm pretty competitive, so my heart rate gets up really high, higher than my doctor likes to see it.
Oh boy.
And then also my condition allows me to scuba dive. That's not normal for people with a defibrillator, but I am able to do that with my doctor's permission.
Wow.
So I'm pretty active, and I try to stay active because that's always healthy for the heart to be more active, to be as active as you can. But again, my doctor has told me specifically, I am not allowed to use my device as a reason to not do something. So I get out there and I do it. I do
I
everything.
love it. I love that. It's a good reason to live life. Well, thank you so much. We really appreciate all of that. And again, I'm going to encourage folks to drop any questions in the Q&A feature. I also want to mention this is the first time Doug actually is filming in front of a live studio audience tonight, which is the first time we've done that. And so far, so good. We haven't heard any heckling yet. So, so great. Let's have folks drop their questions in again. And Heather, if you just want to pop up the Q&A slide for a quick second, just to remind folks, this is the question portion. And so we're going to have all of the presenters on because there's a variety of questions coming in here. And so let's get rolling. First and foremost, I am not a candidate for an internal device, but have cardiomyopathy with heart failure. Is it advisable to get an ASD or external portable defibrillator at home? And I am going to ask Doug or Dr. Savona, which of you would prefer to answer? Dr. Savona, would you like
I'll defer to you, Dr. Savona.
Sure. Yeah. So that's a great question because most of the time when we make our decision about putting an implantable defibrillator, it's based on things like after being, after you're diagnosed with a cardiomyopathy, there are certain things that we typically do. The most common cause in the United States for having low pumping function is coronary artery disease. So our first step is make sure you don't have coronary artery disease. And then after that, we put you on the medicines to treat heart failure, and we reassess the pumping function after about 3 months. And if your heart pumping function is below 35%, then we would consider putting a defibrillator in. But if it's improved, then that's actually been shown to indicate that your risk of having one of these bad arrhythmias is low enough that you wouldn't need a defibrillator. Certainly, there are people who we think might be higher risk for whatever reason. And in those cases, a discussion with your cardiologist about even a wearable defibrillator, which is an external defibrillator that's worn almost like a jacket while you don't have an implantable defibrillator, is an option.
Mm-hmm.
But, having a defibrillator at home, I would say that would probably be, I would recommend talking with your cardiologist because everyone's situation is different. I wouldn't say everyone with a cardiomyopathy should have a defibrillator at home.
Okay.
There may be certain situations that are very specific where someone may say that, but I would say in general, if the decision is made that you don't need one, then that should indicate that the risk of having one of these bad rhythms is low enough that one isn't warranted.
Okay. Okay. Good to know. Thank you. Kim asks a question that's a little lighthearted, I think. Can you sit in a hot tub with a margarita if you have a defibrillator?
From the device side, yes. The device can handle changes in heat, so hot or cold. It can be in freezing weather or in the hottest of heat that we can stand. So yeah, you can be in a hot tub. It depends though on your heart condition. There are some heart conditions that would be aggravated by being in a hot tub or a sauna, for example. So that's something to talk with your doctor about.
Right, absolutely. Doug, what was your ejection fraction when you received your implant, and did it improve?
My EF has been pretty consistent around 65. It's never dropped. My indication for getting a ICD, a defibrillator, was due to runs of non-sustained VT and episodes of fainting. And we could not figure out through days of testing why I was having the runs of non-sustained VT. They kept reappearing. So my device is what's known as primary prevention. I haven't had a cardiac arrest yet, but I'm at risk of one. And so it's there just in case. And usually, typically, people who have defibrillators, their EF may not improve. They will get some pacing support, but it may not improve the EF. Perhaps Dr. Savona, you can follow up on that and fill in a little bit.
Yeah, I think that's very important point, and that's one thing we discuss with all of our patients when we're talking about specifically a primary prevention defibrillator. A little different than a CRT device, but a defibrillator, if we're having the discussion about that, I tell all my patients the device does not make you feel better. If you're getting a defibrillator for primary prevention because your heart muscle is weak, the real role of the device is to prevent you from having sudden cardiac death. It doesn't make the heart muscle stronger. Really, that's the medicines or making sure there's no blockages or things like that. What it can do is if you do have some of these abnormal rhythms, it can do things like pace the heart out of them, which is a painless way to terminate an abnormal rhythm and avoid the shock, which can be painful and uncomfortable if you're awake for it. So I think that's an important point. Now the CRT devices, that's a different device like we talked about with 3 wires instead of 2. Those can actually help people's heart muscles get stronger, because sometimes the reason the heart muscle is weak is because the electricity doesn't flow correctly with the bundle branch block that I had mentioned before. And if we can correct that with a device therapy, then there is a chance that the heart muscle can get better. And in some patients, it actually comes back to normal.
And that's incredible.
And I will note that the medication I'm on has virtually eliminated my non-sustained VT. I don't think I've had a run of VT in probably 3 years now.
Wow. It's just amazing, everything that's coming along in terms of technologies. Julie, there's a question for you here. What happens during a typical device visit or device check? And how do you program or reprogram a device? And those might be 2 different answers.
Sure, yeah. A typical device check is done in a clinic, and you're normally sitting in a chair, and there is a piece of equipment, we call it a wand, that they place over your device, which allows the programmer, which is sort of the computer for the device, to talk to your device. And while you are getting checked for your device, you might notice your heart rate might change some as they're checking to see how well the wires work. There's a couple different values that they look at to make sure that the wires are working correctly and they see your heart rhythm appropriately, and then also can capture your heart muscle if you need pacing support. And then this normally lasts about 15 minutes. And typically it's pretty well tolerated by patients. And we usually do that typically every 3 to 4 months as patients. There's another way that you can check devices via remote monitoring. And most of our patients do that as well. So they have a small sort of looking about the size of a telephone piece of equipment that they keep by their bed. And then the information can be transmitted from that site, with that piece of equipment to your device clinic. And we can get quite a bit of information from the remote monitoring piece of that information downloaded to us. So, and that also has some features that if there is a alert or something going wrong with your device, we will get an alert transmission to try to catch something earlier than and prevent problems.
Interesting. Oh, that's really helpful to know. Let's see, next question. Do women have the devices implanted in locations other than the upper chest? Dr. Savona, is that?
Yeah, there's Doug showed a couple options. One was the leadless pacemaker. There's also a defibrillator that has no leads in the heart at all. It's called a subcutaneous defibrillator, and there's a couple on the market made by different manufacturers. So that would not be in the upper chest, but it would actually be on the kind of the left side of the chest, and the wire runs across the chest and up above the sternum. So that's another device. It's essentially the same device as an implantable defibrillator with a wire in the heart, except it has no ability to pace the heart. So that's one option. There are some other ways that the pacemaker or defibrillator can be placed, like instead of right on the chest, like further laterally or more under the armpit. They used to, primarily when these devices were first designed, they were much larger than they are today. And they were placed in the abdomen, and the wires were kind of run up into the chest. That's exceedingly rare that we ever do something like that. And we typically would not do that just like for a cosmetic reason. It's usually if there's an issue like the veins are occluded or blocked off completely that we would do something like that. But I would say, 90 to 95% of our devices are put in the upper chest.
Okay. All right.
And I know some pretty petite women who have theirs in the upper chest.
Okay. Interesting. Good to know. Thank you. Jason says, as someone in tech for over 25 years, my constant worry is that being 100% paced now at the age of 47 with a heart block. I am constantly scared the battery or the device itself will just fail. And that prevents him from ever getting back to feeling normal. So can anyone talk about, like, does the battery, it does give you warning when the battery is going down, right?
Yeah, actually, I worked in the quality group for Medtronic for a while. I can talk about this. The devices are really, really reliable.
Okay.
They have built-in redundancies so that if some kind of catastrophic failure were to happen, it can still meet the basic pacing function.
Okay.
It can still keep a person alive and feeling relatively well long enough to get to a hospital and have a correction done. But they rarely fail like that. They rarely fail so suddenly that just all of a sudden there's no pacing. When the device is being used normally, a person like Julie who's doing a check can tell you how many years, how many months are left on your battery before it needs to be replaced. So each visit they can say, oh, you've got 3 years and 6 months left on your battery. Well, that's an estimate that the device runs based on how your body is using the pacemaker or the defibrillator at the time. And when it gets to a certain point, there will be an alert or an indicator. It's called elective replacement indicator, ERI. When that happens, there's about 6 months of battery life left on the device. Plenty of time. That's when you start scheduling a procedure to replace the device, maybe in a month or two. And then if you let it go too long, it'll hit another indicator called EOS, end of service. And even at that point, you still have at least 3 months of battery life left on the device. Plenty of time. That's usually a little, if you ever reach EOS, they're going to have you replace the device within a week or two. They're not going to let you go too much further. But there are many, many safeguards in place to prevent a device from just completely shutting down like that. It very, very rarely happens.
That's very good to know, because there are a couple questions in here that are about that kind of fear. So that's very encouraging.
I don't know if Julie may, she very involved with our device checks. Maybe could you comment on how we check, like leads and things like that when patients come in? Because I know that's a concern every time we put a device in, like, are the leads going to work? The battery, like, is it going to fail? So just it may give people peace of mind to know how much, it's quite an extensive evaluation when they come in.
Mm-hmm.
Yes, the battery is checked every time that you come in for a clinic visit, and that is something that if you are utilizing remote monitoring is checked nightly to confirm that you do have battery remaining. And if you reach any of those indicators that Doug mentioned, we will get an alert sent to our clinic to know immediately that the following day that your device needs to be replaced. We also are checking through this remote monitoring. We also can check the function of the leads as well, and making sure that they are appropriately capturing the tissue. And if there is issues with the structure of the lead, that also will be sent to us directly overnight or that night to let us know, so that we can call you and bring you into clinic to confirm that everything is working, or if we need to adjust something, we can do that straight away.
Oh, that's good to know.
And Jan, I actually experienced that with my remote monitoring. I got a call one day from my nurse practitioner who said my device it looked like it was capturing T-wave oversensing, which basically means that my device is double counting my heartbeat unintentionally. Now, with a defibrillator, that's not an issue if you're walking around at 70 beats a minute, then it thinks I'm beating at 140. But if I start to exercise, that can be a problem. So that was not really an emergency. I got the call on Monday. I went in on Friday. I didn't exercise that week, but I went in on Friday and they were able to reprogram the device in a way that will prevent that from happening. So remote monitoring is amazing. The device runs the check every night to make sure that everything is functioning. And so again, there's really not anything to worry about of a device just suddenly failing to operate.
No, that's great to know. Actually, Julie, there's a question in here specifically. Tell us about your role and how you work with patients, if you would.
My role is as electrophysiology nurse practitioner. So I see patients who have electrophysiology concerns, and so that sometimes it's just arrhythmias, sometimes patients with implantable devices. I also work with the device clinic when they have problems. When we see these issues on remote checks or in clinic, they come to me for management of what's the next steps to do with that patient, what needs to change, or if the patient needs to be brought in. So I get to deal with all of those things on a daily basis.
And that's excellent. That's good to know. They're lucky to have you.
Thank you.
So how long do most devices last? Is there a number, a certain number of years?
So pacemakers in general last about, we say around 9 to 11 years.
Wow.
And defibrillators last about 5 to 7 years. CRTD devices are roughly in the same amount as ICDs, so that 5 to 7 marks. It depends how much energy the device needs to capture their heart muscle, and how often you use it, or if you've gotten shocked. So those are just averages, but it can vary a little bit based on your clinical condition.
Okay.
And my device doesn't pace me and it's never shocked me. So mine's estimated to last about 12 years.
Okay, interesting. Well, that makes perfect sense. Now, Jamie asked, when I need a replacement, can my current pacemaker be replaced with a wireless one? I would have that question.
I'll tackle this one, I think. So, if you have the wires in the heart already, the lead, I would presume that your physician would replace it with the same type of device. The leadless pacing system is great in the fact that it doesn't have leads. But right now it's really limited to only pacing the bottom chamber of your heart. There are some clinical trials underway where they have what it's called a dual chamber leadless device, but those are still investigational. The leaded pacemakers, typically, I would say the majority that we put in are one wire in the top chamber and one in the bottom chamber. And for most patients who get those, it would probably be the best to continue using those, because you would still have the lead in the heart anyways, and it would be good to continue using that lead. But we typically don't just abandon the lead and put in like a wireless pacemaker, because there's certain functions that you would probably lose with making that change.
Right. Okay. Interesting. That makes sense. So a couple of questions here that are for Doug. Do you find hot weather, 75 plus, can have a negative effect on your energy level? And then there's another question: what are your beats set at?
Okay, I kind of enjoy the heat. That's usually when I take my road bike out and I sweat off a few pounds. My device is set. I don't require pacing, and I actually have a very low resting heart rate. I think probably because I'm pretty active. So my lower rate is set at pacing rate is set at 40. Okay. And my device will start monitoring my heart a little closer when I hit 166 beats a minute. that's when it's starting to watch me. My
Okay.
shock zone is set for, it was set for 188, but I made my doctor angry a couple of times as I exercised really hard. I shouldn't get my heart rate up that high, but I would get it up around 170 at some time. So we bumped that up just for safety margin. We bumped that up to 194, I believe.
Okay.
So I've got a little bit of safety margin just in case I push it too hard one day.
Okay. That's a good idea.
I don't want to get shocked by accident. And my device is watching just to, it's a very sophisticated device, but it can get confused sometimes. So if I ever hit 194 through exercise, I can't imagine I ever would. But if I hit too high and my device isn't sure if my heart rate is natural or if it's a fatal
Right.
rhythm, it'll shock me just to be safe. It'll shock
Right.
me just to make sure that I'm not in trouble.
That's its job, so it's doing its job. And are there any exercises someone should avoid to prevent lead fractures? And this person says they do weightlifting.
Yeah, that's a good question. Maybe Dr. Savona can tackle this, but I will say there are weightlifters out there. They are the extreme. They are really pushing the limits of the technology. It is, this is a lead wire. It's made of silicone or polyurethane, and it can break. I mean, if you keep bending a paper clip, it'll eventually break. These are really very strong. They don't fracture very often, but there are some exercises. I don't do, bench presses, laying on my back and pressing up with heavy weights. It's just not comfortable for me. I actually can feel my muscles pulling against my device, and I don't like how that feels. But I do a lot of other weightlifting, lateral pulls and dumbbells and things like that.
And how long do the leads last if they're treated properly, I guess I would say?
Usually a
Dr.
device
Savona.
lead will last about 15 to 20 years.
Oh,
It's
wow.
typical.
Wow.
And some last a lot longer. So
Okay. That's amazing, actually.
and our rule of thumb
Dr.
for weightlifting is usually nothing greater than 5 pounds or 50 pounds. Sorry. Go ahead, Dr. Savona.
Yeah, I was going to ask Dr. Savona, what do you recommend to your patients?
No, that's all kind of, the one thing I would add is typically if you hunt, we recommend, we're in Ohio, you have a lot of people who hunt. So if someone like puts the butt of the gun on the left shoulder, we'll typically put the device on the opposite side. So those are just some considerations we typically give for device, like, somewhat talking about hobbies now. I agree with Julie in terms of the weight restriction, not saying you can't do weightlifting, but it needs to kind of be somewhat limited because we would hate for like a lead fracture or something to happen. So.
Okay. No, that's a good consideration. When you get shocked, are you supposed to call 911 afterwards? What's the protocol? Do you go to the hospital? Dr. Savona, would you like to take that, or Julie?
I think Julie maybe can take
So
that.
usually our rule of thumb is, although it seems maybe the first shock, if you feel okay after you've been shocked, then we recommend that you call us, and then we will have a transmission sent, ask you to send a transmission, or if you don't do remote monitoring, we'll have you come in.
Okay.
If you do receive more than 2 shocks in a 24-hour time frame, we recommend that you call 911 and have them take you to the hospital. Don't drive yourself. But that's usually our rule of thumb. First time, a lot of times people that first get shocked for their first time, they tend to want to come to the ER just because it's so unnerving, because they just want to make sure everything's okay. So that's understandable, but really it's fine to contact the clinic and we can take you from there.
Okay.
Yeah, that's my rule of thumb as well. I would say though, I always tell patients if you just don't feel right or you aren't comfortable with it, by all means, like come in and get it checked out through the ER. We never say don't come in. If you don't feel right and want to check, then definitely come in.
Okay. Just err on the side of caution.
Yep.
We have a lot of questions and only about 5 or 6 minutes more. So let me see. Patrick asks, I had a massive heart attack and then CABG times 4. Someone's going to have to tell me what that means. And now getting defibrillator installed tomorrow, 11 months post-op. what's the recovery? What should the recovery look like for me? Should it also be 8 weeks? What's CABG times 4?
So that's a bypass surgery, essentially. So they had coronary artery bypass surgery.
Okay.
The recovery rate would be the same as Doug had mentioned before. It shouldn't, I don't know the situation specifically, but I would say having put in devices on people who've had this CABG procedure, then, the typical recovery would be the same. The recovery from the defibrillator will be much easier than recovery from CABG. So we see patients all the time who've had like valve replacement or bypass surgery or some other, and really the pacemaker defibrillator recovery is nothing compared to like a heart surgery. It's really pretty straightforward and shouldn't be terribly limiting. So he or she has already been through the tough part. So
The worst of it. Okay.
One thing I'll recommend that helped me out was using ice to keep the swelling down on the implant site. 20 minutes on, 20 minutes off for as long as I needed. That was so helpful to it just keeps the swelling down, and it made the incision site feel a lot better.
That makes sense, of course. That's a great idea. Interesting question here. My father is 78 with end stage cancer, and he has a pacemaker. When it's his time to pass, what should we think about? What are considerations about his pacemaker that we should think about?
I may tackle this one. So we see this not uncommonly. We have a pretty large, you showed a great informatic about the Ross, but we also have a just as large, if not bigger, cancer center at our hospital. So we see lots of patients who are in this situation. Okay. End of life is a challenging time for the family, patient, everyone involved. And there's a lot of reasons why people pass away. Pacing is not going to be felt by the patient at all. And to be honest, as people get sicker, there's a certain point where even the pacemaker may deliver a stimulus, but if someone is so sick, it won't cause the heart to beat. So the heart can be sick, and even though there's an electrical stimulus provided to it, it'll never be enough to make the heart beat. And usually at end of life, that's kind of what we tell patients. So if someone is completely dependent on their pacemaker, we typically don't turn it off because that is a completely different situation. Mm-hmm. But if someone paces periodically or very rarely, then we could always talk about, lowering the amount of pacing. But it's not going to be something where the patient continues to suffer just because the pacemaker's on. Usually if someone's at end of life, they typically pass away for other reasons, and they're not like suffering or having life prolonged just by having the pacemaker on. The defibrillator is a different situation. Typically, if people are kind of at peace with where they are and accepting that they're going to pass away, we typically turn off the shocking therapies from the defibrillator to avoid any discomfort. Mm-hmm. And that's something we can program externally. It's not something where we have to do like a procedure or anything. So those are kind of two scenarios that we encounter not infrequently. So,
okay, I'm sure that's very helpful. Thank you. Couple more questions here that are kind of related to each other. Do most primary ICD patients also take pharmaceuticals to help heart function or reduce arrhythmias? And then the other question that's related is, do people with devices have to take blood thinners?
So in terms of blood thinner, no, usually not. There may be rare situations where we recommend a blood thinner, but that's typically people who have multiple leads in their heart, who've had multiple devices, and that's a very unique situation. So I would say 99.9% of patients with devices do not need a blood thinner. Mm-hmm. In terms of the first question, I would say also 99.9% of people would be on a medicine, because in order to qualify for a primary prevention device, you typically need to be on heart medicines for at least 3 months prior to the device going in for the device to be beneficial for you.
Okay. Okay, great. We have a couple of questions related to travel, and this will be the last question we'll take tonight. And if we didn't get to all the questions, we'll follow up with some additional answers in the next few days. I like to travel. What's the best way to go through security screening at the airport? Doug, is that one that you could take?
Yeah, actually, probably 20 years ago, there was a concern about that because the devices would be impacted by magnetic fields, and the security environment was a pretty high magnetic field. That actually is not a concern anymore. The devices were redesigned by all of the medical device companies in the early 2000s. So first of all, they're redesigned to prevent that problem. They're shielded, and the security environments now they're so much more efficient with their energy that it's really not a concern at all. All of the medical device companies recommend that if you're going to walk through the metal detector, you just walk through at a normal pace. Don't stop under the archway and don't touch the archway. The millimeter wave scanners are perfectly safe to use. That's the one where you stand your hands up and it rotates around you.
Okay.
And then the wands are also safe. Typically, though, ask the security personnel, don't hold the wand directly over the device for a long period of time. Don't wave it repeatedly, which they don't usually do anyway during their screening. Personally, I don't even mention that I have a device anymore. I just go through the security screening. And if the metal detector happens to pick up on my device, that's when I tell the screener I have a device. They usually will want to do a quick hand check around just to make sure I don't have something under my shirt, and I'm on my way. It's maybe a 5-second delay.
Okay, all right, fantastic. That's good to know, I'm sure, for everyone on tonight. And hopefully we'll get back to traveling like we used to, right? Despite this situation we're still in. So first of all, I just want to thank all of you for being on tonight. It's really my great pleasure. I mean, we could spend another hour with all these questions coming in, but thank you, Dr. Savona. Thank you, Julie. Thank you to Doug. We really appreciate all of your time and knowledge and insight. So I would like to run a quick poll before people leave about your knowledge gained tonight. This is really helpful for all of us. On a scale of 1 to 5, rate the level of knowledge you gained during tonight's webinar. And I didn't hear too much new info. I learned a little bit. I learned a good amount. I learned a lot. Or this was the most education I have ever received on the topic. We'll give people a few seconds. And then stay tuned for some resources we're going to share right here at the end. A great mixture. Only 1 or 2 said that they didn't learn much new information, but the majority learned quite a bit. So that's fantastic. Excellent. We'll end that poll. That's for our own records. And next slide, please. So to learn more about the DCM Foundation, please go to dcmfoundation.org. Follow us on social media. To learn more about Doug, please go to his YouTube channel, which you see there listed. Also, this information will be sent in a follow-up email along with the recording of tonight's webinar. Doug also runs a couple, or moderates rather, a couple of Facebook groups. The topics there you can see: Living with an ICD, Pacemaker Support Group, etc. And to learn more about Ross Heart Hospital, you can go to wexnermedical.osu.edu. It's a long URL there. I will also include that in a follow-up email. And next. And we would love if you would save the date for our next webinar, which is Wednesday, January 18th, 2023. And we will be talking about new patient support programs we are offering next year and tips for your DCM journey. So that promises to be a really exciting event. The information for that will be up on our website tomorrow. And again, thank you all for joining. Thank you for all of the amazing questions, and happy holidays, everyone. Stay safe and be well. And we'll see you next time. And Doug, your audience did a great job. I didn't hear a peep.
Thank you.
Maybe they should clap now though, right? They should send us out with like an audience clapping. So anyhow, thank you all. Really appreciate your time. Take care now.
Have a good night.
You too. Bye-bye now.